I'm back, and we're almost done for the day. Okay, so toxicology it's tough if you don't do it on a regular basis, and there are several questions on the test, so I'm going to try to get you some pearls to get you through your test successfully. All right, we're going to start with a couple questions, and we're going to do a couple questions at the end. So a 16-year-old male is brought by ambulance to the emergency department from the scene on a Saturday night. He's awake but confused. He's grabbing at invisible things in the air. His temp is 37.9, heart rate 140, respiration 12, blood pressure 138/96, and SATI 99% on room air. His pupils are 7 millimeters. He has dry mucous membrane, skin is warm and dry, and he has hypoactive bowel sounds. So which substance is the cause of this clinical picture? Salicylate, anticholinergics, sympathomimetic, or opioid? All right, excellent. The answer is anticholinergic. Okay, next question. A 16-year-old female is also brought to the ED by EMS from home on a Saturday night. She is sleeping with sonorous breath sounds. She arouses only to physical stimuli. She has bright green vomit on her face and clothes. Occasionally, she makes jerky movements of the arms and legs. Her vital signs are a temp of 37.7, heart rate of 140, blood pressure 130/90, respiratory rate of 4, and SATI 92% on room air. Her pupils are 2 millimeters. She has moist mucous membranes. Her skin is warm and dry. She has several superficial linear abrasions on both forearms. So what did she take? Anticholinergic, sympathomimetic, polypharmacy, or opioid? We're supposed to put the questions up there. There we go. All right, and actually the answer is C, polypharmacy. Okay. So we're going to talk about toxidromes. We're going to talk about what they are, what kinds they are, okay, and how you can figure this out, okay? Which substance is not toxic in low doses? So there are 3 toxic ones. There's one that's not. All right, and the correct answer is C, bleach. And again, we're going to go over this also. And finally, a toddler is found with a bottle of his mother's propranolol. Mother states several pills are missing. The patient is bradycardic and hypotensive. What is the antidote for this ingestion? All right, great. The answer is glucagon. All right, so let's go through everything. So over 2.5 million reported human exposures to the poison control centers are reported each year. 50% of these reported cases are in children less than age 6. It's mostly unintentional ingestions in little kids. 30% of all intentional ingestions reported to the poison control centers are in children 6 to 19 years of age. That's including adults. So kids make up 30% of intentional ingestions. So the most common pediatric exposures are, cosmetic products. Cleaning agents are probably one of the biggest ones on the list. Analgesics, also big. Cough and cold medications, plants, antihistamines, and pesticides. I think if I had to lump it together, anything you can find in your house that you didn't think to lock up is probably going to be on the list. All right, so drugs and substances toxic in small amounts. Nothing else to say except for memorize this list, okay? Benzocaine, beta blockers, calcium channel blockers, camphor, clonidine, methyl salicylate, phenothiazines, and sulfonylureas, okay? So your heart drugs, your diabetes drugs, and methyl salicylate, that can be like oil of wintergreen, okay? Just know that, but all you have to do is just memorize. All right, so when we have a child that comes to the ED or a patient comes to the ED with an ingestion, or we think somebody has given them something or they've ingested something, it's hard to figure out what they've actually ingested often, okay? But we try to figure out what they ingested. We try to figure out what time they ingested it, how much they may have ingested. We try to find out the names of any medication available to that patient. Like maybe there's an aunt visiting and she has some medications in her purse. We need to know we need to know who's been in that house or who's been in that environment and what's available to that child. What have the symptoms been and what kind of treatments have been given prior to arrival? And ideally, we have the answers to all those, but often we don't. In physical exam, the key elements are the heart rate, blood pressure, respiratory rate, temperature, pupils, mental status, and a skin exam. And then there's something called toxidromes. And like I said, these are important, and there's several test questions about toxidromes on the exam. So a toxidrome is a constellation of signs and symptoms that are suggestive of certain class of toxic substances. And the different toxidromes are sympathomimetics, anticholinergics, cholinergic or anticholinesterase, opioids and clonidine, serotonin syndrome, and sedative hypnotics. And we're going to go through each one of these to kind of help you figure this out. So the sympathomimetics, if someone's ingested too much of that, they get an increased heart rate, increased blood pressure, increased respiratory rate, increased temperature, and they often are agitated, which can lead to seizures, psychosis, mydriasis, diaphoresis. So everything's bumped up. Every single one of those things, heart rate, blood pressure, respiratory rate, temperature, up. Sympathomimetics bring you up. So examples are amphetamines, cocaine, pseudoephedrine, caffeine, or albuterol. All right. Anticholinergics, they also increase your heart rate, blood pressure, respiratory rate, temperature. They can get an altered mental status. They can be delirious, often causes hallucinations in high doses. They also get mydriasis. They have dry, flushed skin as compared to the sympathomimetics, or diaphoretic, dry mucous membranes, urinary retention, hypoactive bowel sounds. So the most common case is antihistamines. Some kid takes way too much Benadryl, cyclic antidepressants, antispasmodics, Jimson weed, and atropine. So it's very slight difference in those, but it all revolves around the skin. And this is that red as a beet, dry as a bone, mad as a hatter is the anticholinergics. Cholinergics and anticholinesterases, it's variable what the heart rate does. The respiratory rate goes up. They have really little temperature or blood pressure change. They're often confused, which can lead to coma. They have meiosis. They're sweating. They're diaphoretic. They have bronchorrhea. They're vomiting. They have diarrhea. So everything's just, I just think of it, everything's just kind of spewing out of them, okay? Everything's spewing out. They're wet. They're sweaty. All the orifices are going crazy. So these are the organophosphate pesticides, nerve agents, gases, and nicotine. Thankfully, we don't see much of this, but it still could be on the test. Opioids and clonidine, they lower everything, okay? So your heart rate goes down, your blood pressure goes down, your respiratory rate goes down, they can even be apneic, temperature goes down. In lower doses, they can be euphoric, that's why people do it, and that could progress at higher doses to lethargy or coma, and their pupils are miotic, and examples of these are obviously the opiates, clonidine, and then tetrahydrolazine, eye drops, which would be your Visine. If a kid drinks a bottle of Visine, that's important. You need to call somebody. Serotonin syndrome, that increases your heart rate. It's variable what it does to the blood pressure. It increases the temperature. Often causes agitation, which can lead to confusion, which can lead to mania and coma. They have mydriasis. They're hyperreflexic. That's the big exam finding. And they often have myoclonus. They could have seizures or rigidity. And your examples are your obvious SSRIs, meperidine, ecstasy can do this. And they can get rhabdomyolysis because of all the hyperreflexia and agitation, and they can have a lot of problems. And then finally, our sedative hypnotics. They also decrease things. They decrease your blood pressure, respiratory rate, and temperature. They really don't do much with your heart rate, which is the difference between sedative hypnotics and opioids. Opioids bring your heart rate down also. They get slurred speech, ataxic, their depressed mental status, they get mydriasis, or their pupils may not even be affected. Examples of this are benzos and barbiturates and quinone. Okay, so the management, same as everything else, like I said, ABCs. Any test question, if it says, what's your first step in the management of this patient, go through your ABCs. Don't jump to testing, okay? Because they will trip you up on that. So ABCs. Check a glucose on any patient comes in with an ingestion, and treat with IV glucose if hypoglycemia is present. We're going to treat any hypotension initially with normal saline boluses. The labs that we may obtain for ingestions include a BMP and potentially a venous blood gas. They can be helpful. We may obtain, depending on what they took, drug levels for specific substances. And often, drug screens are not helpful in the acute management of the patient, because it takes some time for these to come back. So in the initial management, you stabilize the patient. It doesn't mean we don't get a drug screen, but in the first several minutes to an hour, they're not all that helpful. Okay, GI decontamination. Syrup of Ipecac, back in the day when I was a resident, they used to give it. It has no role at all in the management of ingestions. Gastric lavage, again, that used to be a big thing too. We've gone away from that, limited or minimal role. And it has to be done, if someone's going to do a gastric lavage, you really need to catch that person within the first 30 minutes of ingestion, which is rare. And little kids are difficult with the tubes, and the pills just don't get evacuated. Activated charcoal is still used for some cases. It may have some effectiveness if used within the first hour after the ingestion, otherwise it has minimal benefit. There may be some role of multi-dose activated charcoal in some ingestions. I haven't used activated charcoal in probably over a decade, so it's not going to, if you see it, it's probably not the right answer, except for a few limited situations. But we used to give it all the time, and little toddlers would be drinking this black stuff, and it was awesome. Not anymore. All right, so single-dose activated charcoal should not be administered routinely in the management of poison patients. It may be considered if a patient has ingested potentially toxic amount of a poison up to 1 hour previously, so which is pretty rare to catch someone within that first hour. And there's risk to it. If they have an unprotected airway, they can vomit and aspirate charcoal, and they haven't shown a real benefit to it. Okay, there's also whole bowel irrigation. It may be used for the ingestion of large amount of sustained release products or in body packers. That's when drug dealers, things like that, they stuff a packet of cocaine in different orifices, okay, and they need to get it out. They may do that. And then finally, hemodialysis. There's very specific uses for this. It's not very common. The one example that we may use it in is severe aspirin toxicity. Okay, antidotes, again, you just got to memorize. Narcan or naloxone is used for opioids, flumazenil for benzos, fomepizole is for methanol or ethylene glycol ingestions, N-acetylcysteine is one we use probably the most, is for acetaminophen. Pralidoxime is cholinesterase inhibitors, and I've never used that in my life. And digobind is for digoxin. It's the only thing that will help a digoxin overdose. Okay, so we're going to go through some specific ingestions. Acetaminophen is probably the most common one we see because it's a common household drug. It's used frequently. It's very easily accessible. We see both intentional and unintentional versus chronic / over-medicating patients. So sometimes you get that little kid who has a fever and grandma's helping out and mom's giving them Tylenol and dad's giving them Tylenol. Next thing you know, the kid has a little bit of an overdose. Unintentional. And little kids like it. It tastes yummy, right? Tylenol's good stuff. So they drink it up. Intentionally, you see with the teenagers, they can go to any drugstore. No one's going to question a teenager about buying a pack of Tylenol, okay, or a bottle of Tylenol. Unfortunately, the complication can be fulminant hepatic failure. Thankfully, little kids, younger children, do much better than the teenagers with that. All right, so how does this all happen? Acetaminophen's metabolized in the liver. A small percentage is metabolized by cytochrome P450 into a toxic intermediate compound called NAPQI. So at recommended doses, the NAPQI is conjugated with glutathione, and this creates a non-toxic metabolite, which is excreted in urine and bile. In overdoses, your glutathione stores are depleted, but you still get that toxic buildup of the NAPQI, and then this binds to hepatocytes, and that causes your hepatic necrosis. Okay. No one's going to ask you about the metabolism except for the liver, but this is this part, there was a question just on my test the other day, all about this. So the 4 classic stages of acute acetaminophen toxicity. Stage 1 is the first 24 hours. You get anorexia, nausea, vomiting, malaise. They may have a little hypokalemia. Stage 2 is the days 2 and 3. They can get abdominal pain, hepatic tenderness, somewhat improvement of their anorexia, nausea, and vomiting. That's where you get your elevated serum transaminases, elevated bili, and prolonged PT if it's a severe ingestion. Stage 3 is your days 3 and 4, and that's recurrence of anorexia, nausea, vomiting. They may get an encephalopathy, anuria, jaundice, a metabolic acidosis may develop as well as coagulopathy, renal failure, and pancreatitis. So it's like stage 1, they feel a little sick. Stage 2, they're getting a little better. Stage 3, now the bad things are happening. Stage 4, it happens after day 5, and you either get a clinical recovery or you deteriorate into multi-organ failure and death. So basically your labs get better or they get worse. Okay. So toxic exposure is likely when an adult ingests greater than 10 grams or 200 milligrams per kilogram in a single ingestion or over a 24-hour period of time, or greater than 6 grams or 150 milligrams per kilo for 2 consecutive days. All right, so we plot this all out on the Rumack Matthew nomogram, and this applies only in the setting of acute exposure. For those kids, for chronic exposures, it doesn't apply, but it's in the time setting of 4 hours to 24 hours after the ingestion. So if you get a child and it's 2 hours after they took a bottle of Tylenol or a handful of Tylenol, you have to wait until 4 hours to get the level because it doesn't make sense to plot it out on the curve. Additional lab studies that we often attain are electrolytes, glucose, TBC, coags, aspirin level, because co-ingestions are common, a urine tox screen to see if they did anything else, an electrocardiogram if indicated. So the management for proven or suspected overdoses, we give N-acetylcysteine. It's best if it's administered in the first 8 hours. There's a loading dose of 150 milligrams per kilogram IV or 140 milligrams per kilogram orally. We try to do it IV nowadays because it's hard to get people to drink all that stuff. This is followed by continuous dosing for 20 hours if IV or 72 hours for oral, another reason why we try to use IV. However, we need to monitor for anaphylactoid reactions if using the IV formulation. Salicylate or aspirin. Thankfully, there's been reduced poisonings in the United States due to increased use of aspirin alternatives, childproof containers, and education on the association with Reye syndrome in children. However, there's a big lack of awareness on what contains aspirin in over-the-counter medicines. Pepto-Bismol does. Many topical ointments or liniments, like Bengay, things like the sports ointments that people like to rub all over themselves. You can absorb too much and have a salicylate overdose. All right, so the clinical presentation. So what it does, salicylates stimulate your respiratory center of the brainstem, which can cause some early hyperventilation and respiratory alkalosis. It interferes with glucose metabolism, so they can either be hypoglycemic or hyperglycemic. It uncouples oxidative phosphorylation, so it increases heat production, sweating, and dehydration. They get gastric irritation, so nausea and vomiting. As well, it stimulates the chemoreceptor zones and also causes nausea and vomiting. Their system gets messed up, okay? So diagnosis is based on symptoms and acid-base status. The nomogram, there was a nomogram that's been formulated years ago, but it's not been proven to be accurate. Blood levels correlate poorly with toxicity, so aspirin levels are obtained, but they don't really tell you what's going to happen. There's also potential for chronic salicism in patients, so the kids with congenital heart disease that are taking aspirin on a daily basis. Respiratory alkalosis, it causes a respiratory alkalosis with a non-anion gap metabolic acidosis. It's where knowing how to calculate an anion gap is important. Hypokalemia is frequent, but you could see either because of the metabolism problems, hyper or hypoglycemia. So the management of this, we're going to support our ABCs. We have to be careful about this thought of intubating these patients because their respiratory rate is pretty high, and they're doing that to kind of blow off some of the acid. So if we take away their airway and intubate them and place them on a ventilator, we need to keep up on the respiratory rate that was at their baseline. Because if we slow down that respiratory rate, the acids are now going to build up, and this patient is going to get a lot worse. Okay, so we just kind of like a diabetic patient, we try to let them maintain their airway as much as possible. We give normal saline boluses to restore their volume because they can get dehydrated. We monitor their urine pH, aspirin level, glucose, electrolytes, and we get hourly venous blood gases. We can add glucose to the fluids after initial fluid resuscitation, and then alkalinizing the serum and the urine to enhance aspirin protein binding and urinary elimination is the best thing you can do. So sodium bicarb in the fluids. And then for children not responding to these or severe toxicity, hemodialysis is considered. Okay, NSAIDs, common household medication. Everyone has it. Again, easy access. Thankfully, it doesn't do much to you besides cause nonspecific signs like abdominal pain, nausea, vomiting, headache, nystagmus. Some kids get a little altered if they take too much. They can become hypotensive. Renal insufficiency is a potential, but often doesn't happen. So the management of this is IV fluids, pressors if they're hypotensive, that's not responding to fluids, and benzos for seizures. I've yet to see that happen. So beta blockers, we see this often in kids in the emergency department because beta blockers are used both in children and adults to control hypertension and arrhythmias. It's also used for congestive heart failure and angina. So what they do, they block the beta receptors by modulation of the calcium-mediated excitation contraction. Clinical effects is the cardiovascular system is the one primarily affected. Overdose is common in children. Thankfully, serious intoxication is rare. However, in the older kids, that might not be the case. So toxicity usually develops within 6 hours of ingestion with the immediate release products. Effects of sustained release are seen about 8 to 12 hours. So what it does, it decreases cardiac contractility and conduction delay, causes a conduction delay. So common findings are hypotension, bradycardia, conduction delays, depressed mental status, coma, seizures, and bronchospasm. Okay, so just know those symptoms for a test question. So the goals of therapy, we want to restore cardiac output by increasing heart rate and improving the myocardial contractility. So we give IV fluids for hypotension. Glucagon, what it does, it affects the inotropic and chronotropic kind of system of the heart. So it's the first agent of choice for toxicity. We add vasopressors for the treatment of refractory bradycardia and hypotension. Hyperinsulinemia, euglycemia therapy. So what we do, we give insulin and glucose together, and this may improve the myocardial contractility of the heart. Calcium channel blockers are my most dreaded ingestion ever. Most common agents are verapamil, diltiazem, nifedipine. So they inhibit calcium flux through low voltage channels in cardiac and smooth muscle, as well as the pacemaker cells in the SA and AV nodes. They cause vasodilation, myocardial depression, and slowed nodal conduction, and they can progress to fatal arrhythmias. There's many sustained release preparations on the market, so the symptoms may develop early, but may not develop till about 12 to 24 hours after the ingestion. So it again affects the cardiovascular system. They can get bradycardia, AV block, hypotension, like I said, fatal arrhythmias. They often are hyperglycemic. They can get non-cardiogenic pulmonary edema and lactic acidosis. And hyperglycemia is common, and that often helps distinguish a calcium channel blocker from a beta blocker, where they often are hypoglycemic. It's subtle, but that's the only thing. Management's tough with these because not much works. But we're going to try to increase the cardiac output and systemic vascular resistance. So we give IV fluids for hypotension. We give calcium gluconate or calcium chloride. But because there's such enormous binding of all the calcium receptors, sometimes calcium does very little in the case of severe toxicity because there's nowhere for that calcium to go. Vasopressors for refractory hypotension and bradycardia. Glucagon has probably minimal success in calcium channel toxicity. Hyperinsulinemia, euglycemia therapy, it may or may not improve myocardial contractility and blood pressure. IV fat emulsion, something called intralipids, is showing some success. But some people don't, their hospitals may not have intralipids, but they are hidden in the anesthesia department. But we've had several deaths to this because it's like the most difficult ingestion to treat. So if I hear a calcium channel blocker, I get really nervous. Clonidine, this is what I see the most in the emergency department. clonidine overdoses. So clonidine is a centrally acting antihypertensive agent. It has really widespread use. It's used for hypertension, narcotic withdrawal, ADHD. It seems like a lot of kids are on that. What it does is stimulates central alpha receptors. There's no peripheral alpha receptor activity. It causes hypotension and bradycardia. It causes CNS and respiratory depression, so everything's going down, and hypothermia. So respiratory rate, heart rate, temperature, everything drops. So management's really supportive. However, respiratory depression and apnea are more common in young children. We give IV fluids like everything else. We may need to give vasopressors for hypotension that's refractory to IV fluids. Atropine is sometimes given for symptomatic bradycardia. And then Narcan may be useful in cases of refractory hypotension or altered mental status. That's actually, I should change the slide, that's our first treatment, and we give a lot of it. We'll give little kids 10 milligrams of Narcan just to wake them up and then put them on a Narcan drip. So, because they often need high doses just to keep them breathing on their own. And it's amazing, we can give Narcan, a kid goes from like completely out of it to a screaming little 2-year-old, which is not what you want either, so then they're difficult to get down, but it works really well. So anticholinergics, the clinical findings of that, you can get hypo or hypertension, tachycardia, hypoactive bowel sounds, urinary retention, flushed skin, hyperthermia. Like I said, dry skin, that was the factor that's needed the most. Mydriasis, confusion, agitation, disorientation, hallucinations. Antihistamines are the most common. Jimson weed is also out there too. I haven't seen as much Jimson weed in the past decade, but I've seen a lot of Benadryl overdoses. Potential complications, status epilepticus, hyperthermia, cardiovascular collapse, and rhabdomyolysis, because in high doses it acts like a sodium channel blocker and can cause all kinds of problems. So the treatment is primarily supportive. We monitor their temperature because they can become hyperthermic. We treat their agitation with benzos, like something like Ativan. We treat their seizures with benzos. We don't give phosphonatoin because it can cause cardiac arrhythmias in these patients. We treat their wide complex tachycardias with sodium bicarbonate because, like I said, it is a sodium channel blocker at high doses, so sodium bicarbonate is the antidote or the treatment plan for this. Physostigmine is controversial. It's rarely used. I've never used it, but it can cause, if it can worsen cyclic antidepressant toxicity and lead to fatal arrhythmias. So if they're asymptomatic after 6 hours, you can discharge them. However, often these kids need to be admitted for 24 hours or more if they're symptomatic. And most often it's their heart rate and the agitation that keeps them in the hospital. Tricyclic antidepressants, amitriptyline, nortriptyline, doxapen are very common ones. Amitriptyline is Elavil. It's used for headache treatment nowadays, as well as depression, for migraines, I mean. So they have many pharmacologic effects. The anticholinergic effect, they get an altered mental status and sinus tachycardia. The cardiovascular effects are like a quinidine-like effect. It can depress myocardial conduction, cause PVCs and VTAC. And then you get a QRS widening associated with increased mortality. And this can progress to complete heart block or ventricular arrhythmias. And then they can develop seizures, disorientation, and lethargy. The management, that's the most important thing I can do for a tricyclic ingestion is get a 12-lead EKG because we're looking at that QRS complex to see if it's wide or not. That's going to dictate my treatment. So if they have seizures, we give benzos. If there's conduction delays, meaning the widening of the QRS complex, we're going to give sodium bicarbonate. And then we repeat the EKG and repeat the sodium bicarb until the QRS complex is narrowed. Because again, these act also like sodium channel blockers at high levels. And then we may have to treat any refractory hypotension with pressors. Okay, just a few things about drugs of abuse, and then we're done. Okay, opioids. An opioid is a drug active at the opioid receptor. Opiates are naturally occurring derivatives of the opium plant. And a narcotic, technically, is any drug that causes sedation, and that's a legal term. So opioid toxicity, the toxidrome is pinpoint pupils, respiratory depression, lethargy. Variations depend on how they took it and their tolerance to it. The management is naloxone for the respiratory depression and may require large doses. And then you have to be careful on chronic users, so even teenagers can be chronic users nowadays, because Narcan can precipitate potentially withdrawal seizures. Stimulants, those are cocaine, methamphetamine, ephedrine. They cause euphoria. That's why they take them. The complications are due to the release of catecholamines. They can get myocardial ischemia. They can get myocardial infarctions, dysrhythmias, seizures, intracranial hemorrhages, rhabdomyolysis, and acute renal failure. Cocaine chest pain is a syndrome that symptoms can range from mild tachycardia and chest pain to myocardial ischemia with EKG changes. The management for this is benzos for the treatment of the CNS and cardio effect, and we treat the ischemia and dysrhythmias per standard ischemic myocardial ischemia therapy. And hypertension unresponsive to benzos gets nitroprusside. Hallucinogens, seeing a little bit more of this nowadays too. That includes your LSD, PCP, mushrooms, and ecstasy. Often they get mydriasis, tachycardia, anxiety, and muscle tension. Complications can be hyperthermia, seizures, hyponatremia. Routine drug tests, unfortunately, will not detect most of these substances. And the management is, again, benzos for seizures, agitation, tachycardia, and hypertension. And then they may have to do nitroprusside for hypertension refractory to benzos. Often these people can get rhabdomyolysis because they're so agitated that they get muscle breakdown, so we give IV fluids for that. All right, so we're going to do a couple questions and we'll be done. 15-year-old female presents to the ED after telling her mother she attempted to kill herself by taking Tylenol. She will not state when she took the medications. Currently, she is complaining of abdominal pain, had nausea, but is better. On exam, she has right upper quadrant tenderness, lab demonstrate elevated LFTs. So when did she take the med, overdose on the medication? 16 hours, 52, 96, or 1 week ago. All right, good job. B is the answer, 52 hours. So she's in stage 2, right? She initially had some nausea and vomiting, and now she has abdominal pain and some elevated LFT. So stage 2 is days 2 and 3, so that puts her at 52 hours. Okay, 16-year-old male presents to ED actively seizing. He's notably diaphoretic, tachycardic, and hypertensive. His friends show up and are laughing about how their friend is acting. What drug have they been using? All right, good job. It's methamphetamine. So you could probably knock out Demerol and vodka because those depress everything, right? Everything gets slower. Diphenhydramine, that's an anticholinergic. It's not going to make you diaphoretic. So you have a stimulant. That methamphetamine causes diaphoresis, tachycardia, and hypertension. The diphenhydramine will cause tachycardia, hypertension, and they're going to have the dry skin, dry red skin. And that's it. We ended about 5 minutes early.